sir. Thank you, sir. So, I have 30 minutes standing between you and the dinner waiting for you. Leaving you, I'll try my best to finish in 30 minutes. So, this is how I have structured the session for today. We will start off some revision of some basic fundamentals which are clinically relevant. Move on and start with some low flow O2 devices, moving on to high flow devices. Talk a bit about NIV. Spend some time on mechanical ventilator and end with ECMO. In between, I have two quiz questions specifically for our PG residents, and forgot to bring the 5 stars, so pardon me for no gifts for the right answer. So we will start. So as I told, we will start off with revising some basic terminologies, right? We have all remembered two terms, that is the resistance and compliance in lungs, right? So here, what is the resistance? It's basically your opposition to the airflow, and lung compliance, that is basically the ease of lung expansion. You remember the old balloon example and the straw and everything. So why I'm starting off this is, even in ICU postings when we are seeing, people wait for the patient to desaturate to act, right? It's not always the desaturation. Always look out for an increased work of breathing. So work of breathing is basically the energy spent by the respiratory muscles to overcome a decrease in compliance and an increase in resistance. So this could be the science which you are missing, so that you are going to tell me, sir, patient suddenly crashed, right? So watch out for the signs of increased work of breathing. That could be tachypnea, use of axillary muscles, inability to speak full sentences. Now, oxygen delivery, it's not always about saturation. Look out for other features which are contributing to a hypoxia, that is basically low blood pressure, low cardiac output, and also features of global perfusion as with low hemoglobin and elevated lactate. So oxygen delivery depends upon 3 independent systems, that is your cardiac function, hemoglobin quantity, and the hemoglobin quality. So unless you correct these things, you are not going to correct the situation. So again, with hypoxemia, remember that it is a multifaceted challenge. It is not always low FiO2. You might be dealing with a shunt, you might be dealing with a ventilation mismatch, you could be dealing with a diffusion limitation, or even a hypoventilation. So basically, we have two tools for correcting the hypoxemia, right? You have the PEEP and the oxygen. So when to use what? So if you have a hypoventilation, theoretically we say that oxygen could be a temporary band-aid and even PEEP may not be indicated. But there is a small caveat right there, right? So here we are talking about a primary neurological reason which is causing hypoventilation. But again, a patient with obesity hypoventilation, again some role of PEEP is there to keep the alveoli open. Diffusion limitation, again partial benefit with oxygen. PEEP is definitely going to be helpful. A VQ mismatch, again O2 is going to be helpful and PEEP is going to be helpful. A shunt, yes, definitely PEEP is going to play a bigger role there. And low FiO2, of course, you have to go with your oxygen. Moving on to the other devices, basically our intrinsic thing is a negative pressure, right? And we used to have negative pressure ventilators long back in our polio days. You remember those iron lung? Anybody remember the pictures? Right? And now what we are dealing with is mostly the positive pressure devices. But there is a dual impact of positive pressure ventilation. Always remember there could be a hemodynamic compromise because of the preload reduction. At the same time, we improve the lung ventilation. So we will start off with the first device, that is the nasal cannula. That's the starting point, right? So few points here. What is the usual rate in which we keep the nasal cannula? Yeah, it's usually 1 to 6. Some people say 1 to 5. So basically, how do you calculate the FiO2? So as I written here, it's a traditional 4% rule. That is for every 1 liter of O2, you add 4%, right? So your room air has 21%. If you are keeping at 5, it is 5 into 4, that is 20, plus 21, that is approximately 41, right? So that's what we are looking at from a nasal cannula point of view. The other advantages could be a comfortable one. Indications, yes, of course, mild hypoxemia, but always look out that the actual FiO2 could be variable. Why? Because there are certain pitfalls. If the patient is having a mouth breathing, right, the delivery could not be, won't be effective. The patient could be breathing very rapidly. There could be nasal obstruction, and also this itself can lead to dry mucosa. So these are the pitfalls which you need to remember when you are keeping a patient on a nasal cannula. But from the resident point of view, these are the things you need to be watch out for. That is when to escalate. You are keeping a patient on nasal pumps, then again escalate if the saturation is persistently below 90% despite 5 liter of nasal cannula. And also if the respiratory rate remains more than 30 and use of axillary muscles are there, There are certain school of thoughts that you need to, if it is not improving within 1 hour, then probably it is time to move on to the next. And also watch out for other features of mouth breathing and dyspnea. Now we are moving on from the nasal cannula to the simple face mask, right? Again here, what's the usual flow? Here it is. Now we are moving on to the nasal cannula, right? It's close to 5 to 10. And here again the FiO2 limits are going to be 35 to 60. The indication would be a moderate hypoxemia, and the advantage, of course, compared to the nasal bronchs, here we are going to achieve a higher FiO2. Pitfalls, again, what happens if you keep the mask and don't give adequate oxygen through it? Again, there could be a CO2 buildup. That's why you keep a mask, you keep 2 or 3 liters O2, your carbon dioxide buildup is going to happen. So when you are keeping a mask, normal face mask, remember that you have to keep at least 5 liters of flow, right? There could be poor tolerance. This is relative compared to your NIV and all. This is definitely more tolerable, right? Again, patient may not be able to take feeds. And false reassurance. Again, we have kept the mask out. Everything is okay. No, don't get into the false reassurance also. So this is something again which is very useful, but very limited experience in our center. That is a Venturi mask. Again, you have the multiple color codes there. So you set the flow, and based upon the color, that's a FiO2 which is being delivered, right? So here the oxygen passes through a narrow jet which creates a negative pressure area, and this kind of draws in the fixed amount of room air, and this delivers a specific oxygen concentration, and whatever color codes you see there, based upon that color you can maintain the FiO2 and flow. Right. Again, definitely this has some advantage in COPD patients. Again, where you want to know the exact FiO2 for blood gas and all, this could be a right kind of a tool. Again, the pitfalls here includes a blocked part or an incorrect flow and misunderstanding of the colors by the staff. So now just a quiz so far. Anyone can identify this device? What could this be? So this was a stainless steel nasal cannula. Okay. Right. This was the beginning of nasal cannula. Now we use so much flexible kind of stuff. This is where it all started, 1930s. Yeah. Sorry. Now, so you can look at the picture there. So you can see the air moving, right? So also remember there are 2 valves you are seeing there on top, right? So at times we keep the mask and you don't even see those valves there, and you are also seeing something down here. So as the patient inspire, the bag is collapsing, and as they expire, it's opening, right? The side valves. So these things has to be there for the NRBM or non-breathing mask to be effective. So here the reservoir bag itself stores a very high FiO2. It's a one-way valve which limits the mixing of room air and exhale gas, and the flow requirement here is usually at least 10 to 15 liters. For the mask to remain open itself, you need to have the flow set at a minimum of 10 to 15, right? So here again very high FiO2 you can reach up to close to 90%, and the key uses very much used in emergency situations as a starting point itself. Pitfalls, again, this gives a false security, inadequate flow and delayed intervention at times. Now what's this? Yeah, this is again your high flow nasal cannula, right? The HFNC. So these are the various parts of the HFNC. You can start with the nasal cannula. You have a heated breathing circuit, moves on to the flow meter. You have an air blender and the sterile water supply for humidification, and the active humidifier and heater. So remember 2 things here. You have a high flow and dead space washout. So this can deliver close to 40 to 60 liter per minute of gas. This flushes the carbon dioxide, and also there is a precise FiO2 and heated humidification. So technically you can reach close to 100% of FiO2 with an HFNC. Now what are the usual indications? Acute hypoxemic failure. Certain situations, definitely in a hypoxemic situation, it has superiority over NIV. And post-extubation support, we might extubate the patient from a ventilator to an HFNC, and there is definitely something, a lot of interest on apneic oxygenation. So apneic oxygenation is where we have a patient who is on very high oxygen requirement. You are going to go for a intubation, and during intubation you leave the HFNC on the patient's nose so that the oxygenation is maintained during the period of apnea, right? Okay. Now, any patient who are keeping on HFNC, watch out for something called as ROX index. So ROX index is nothing but SpO2 by FiO2 divided by respiratory rate. right? This is kind of an indicator whether the patient is going to improve on a HFNC or might need intubation. And the various scores at 2 hours of less than 2.8 or at 6 hours less than 3.85 or at 12 hours less than 3.85 could be an indicator for HFNC, and probably you need to escalate from there. So this is kind of a summary of the whole thing. Don't worry, at the end of that you will be given the slide, so I'm skipping it. Now what's this? Your non-invasive ventilation. I think we'll spend some time in non-invasive ventilation. So here, this is a positive pressure ventilation without an endotracheal tube, and it's delivered via a tight fitting mask or helmet interfaces. So we will go through the various interfaces later. Again, the definitive recommendation for NIV is just for two things. That is your acute exacerbation of COPD and acute pulmonary edema. So both situations, there is a significant strong recommendation for NIV being the first line of treatment. Yes, there is a role for hypoxemic scenario also, but in very select kind of situations like an immunocompromised patient, a patient with chest wall neuro, muscular diseases, obesity, hypoventilation, and always choose the patient right for the NIV. Make sure that the patient is having a good conscious level, reasonable hemodynamic stability before putting the patient on NIV. Contraindications, of course, a depressed level of sensorium, agitation, inability to protect airways is strong contraindication for NIV. Shock, unstable arrhythmias, and myocardial infarction is a relative contraindication, and copious secretions, high aspiration risk, and facial trauma is again a strong contraindication. The two things which we commonly know about is the CPAP and the BiPAP. The CPAP is a single pressure mainly for oxygenation, and remember that the BiPAP has an IPAP and an EPAP, which helps with both ventilation and oxygenation. Now, the CPAP here is a constant pressure, so usually we keep the pressure at around 5 to 10. This is predominantly for oxygenation, as I told, and the classical indications would be for a cardiogenic pulmonary OSA or mild hypoxemic failure. When we move on to BiPAP, you have something called as the EPAP. So EPAP is similar to your pressure support or your CPAP or a PEEP, and this can improve the oxygenation and the alveolar recruitment. Again, the IPAP usually exceeds the EPAP, and it is the difference which is equivalent to your pressure support. Again, becomes the first line of treatment for acute exacerbation of COPD with hypercapnia. There is a definite role for mixed respiratory failure and cardiogenic pulmonary edema with hypercapnia. So, you are with me so far? Right? Okay. Now, what could be a reasonable kind of a cheat sheet for an initiation of BiPAP? This is not like a set rule, but this can be a guiding thing. For acute exacerbation of COPD, probably we can start with an IPAP of 10 to 12, then EPAP of 4 to 5, and a set saturation targets of around 88 to 92. Okay, and also your CPAP for a cardiogenic pulmonary edema, probably we will start with 8 to 10, or if you are starting with the BiPAP, again 10 to 12 of IPAP with 5 to 8 of CPAP. Titration, always go by small steps, increase the IPAP by 2 to 3 and EPAP by 2, and look for, as I told before, for respiratory rate and workup breathing. Again, what happens if there is persistent hypercapnia or acidosis? You go on increasing your IPAP first. When there is a persistent hypoxemia, the tool to go by will be the EPAP, and always, this is the most important thing, always reassess the patient on NIV, right? Also watch out for leak, the triggering from the patient, and also asynchrony. So these are the various interfaces. We are very familiar with the face mask, but there is also something called as a total face mask, the nasal mask, the mouthpiece, helmet, and the nasal pillows. Now we have, from an ICU point of view, most of the time we use a full face mask. Now, when you are keeping the mask, always look for a few things. Choose your interface size. It's not that one mask fits everyone, right? So make sure that you keep the mask, check it on the patient's face, make sure there is no leak and it's fitting properly. Consider keeping foam or gel pads to prevent necrosis. Avoid over tightening of straps and reassess mask fit every 15 to 30 minutes. Okay. Now, this is again very important. Always monitor a patient on NIV. For the clinical deterioration, watch SpO2 and FiO2. Perform blood gas as needed, and it's a trajectory which is more important rather than single point values. Okay, you have a blood gas, you follow up the blood gas, value the trends than a single value. NIV failure, again, certain signs will be a raising respiratory rate, worsening blood gases, increased FiO2, mental status changes, and hemodynamic instability. So watch out for features of NIV failure. Now, when will you switch from an NIV to a mechanical ventilator? Yes, if the pH is worsening, there is a sudden hemodynamic compromise, persistent tachycardia or high workup breathing and new altered mental status, and low PO2 by FiO2 ratio in spite of a reasonable NIV support. Okay. Yes, we will just quickly run through the ventilation part. The usual indications for mechanical ventilation, you have the hypoxemic respiratory failure, hypercapnic respiratory failure for airway protection, severe workup breathing, and cardiovascular instability. Again, usual or traditional mechanical ventilation comes with your sedation and neurovascular blockade. Now, ventilator modes, it's always a alphabet soup. The commonly used one are your assist control, volume control, your pressure control, your volume control with SAMB, pressure control SAMB, the PSV, CPAP, and the spontaneous modes, and you have multiple newer modes which include the dual modes like PRVC, VAPS, VS, MMV, and the closed loops or the smart modes now with ASV, PAV, NAVA, Smart Care, Auto mode. So the last few things are just based upon which model or which company's ventilator it is. They have their own kind of terminologies. So from 90% of the time, these are the modes which we are kind of using, right? We have an assist control. We usually start with volume control or pressure control depending upon the personal preferences mostly. And if you want to give a strong message, this would be it. Usually volume control is a default full support mode. Pressure control when pressure limitations and synchrony is a priority. SAMV, yes, it's fallen off the radar for most of us now. And PSV is your weaning and comfort mode and not your set and forget for unstable mode, unstable patients. Clear? Okay. Again, a cheat sheet kind of thing for initiation of ventilator. So once we start, usually it is most of the patients we start with a 6 ml per kg of predicted body weight, right? So the range is usually between 4 to 8, and your base trial volumes are based upon the predicted body weight. Respiratory rate, again, respiratory rate into trial volume. So basically, what are you managing with your respiratory rate and trial volume? Which factor is it, the hypoxia or the ventilation part? It's your PCO2, right? And then you have your FiO2 and PEEP, which is going to help manage your hypoxia, right? Okay. Plateau pressure. Heard about plateau pressure? ARDS net criteria, you remember? Okay. So we have a target of plateau pressure to keep it below 30, and there is also you have to look after the driving pressures. Okay, driving pressure is nothing but it's your plateau pressure minus the PEEP, where we keep the target less than 50. Okay, and ARDS strategy also all of you will be aware of. So, ventilator associated complications, you have the ventilator induced lung injury, which could be part of your barotrauma, cryptotrauma, or biotrauma. And you have the ventilator associated events as per the CDC tiers. You have the ventilator associated conditions. You have the ventilator associated conditions with a microbiological, with the laboratory evidence of raised WBC or signs of infection, and also probably with a microbiological proof. So here, always remember the prevention bundle for ventilator associated events. That is your pendant elevation, oral care, sedation, lightning, early mobilization, maintaining a good cuff pressure, and subglottic suction. Weaning blood liberation, yes. Make sure that during your rounds, you at least ask yourself this question: that is this patient ready for coming out of the ventilator, right? So always go for a daily awakening thing. That is by your lightening or stopping your sedation. Go for a spontaneous breathing trial if possible, and do a readiness screen. And post extubation, always assess for cough, secretions, mental status, and plan post extubation to an HFNC or NIV if needed, right? Okay, the last question for residents, what are you seeing here? What could this be? That is the country of origin of this person. Yeah, so he was the inventor of the device which we use very commonly nowadays, that is the SpO2 oximeter. So we will end with the big guy in the room, that is ECMO. So we currently have a patient in ECMO in Appella's unit in 5-4 ICU. So the residents who are in such units are quite familiar with the basic circuits and everything now. So basically here you have a pump driven extracorporeal gas exchange, and your venous blood is usually drained. It runs through the pump and oxygenator and is returned to the patient, right? And here it provides O2 delivery and carbon dioxide removal when the lung and heart fails despite of the maximum conventional support. Right? Your heart and lung is failing and you want to buy some time, that's usually when we consider a patient for ECMO. Here again we have two types of, broadly you can convert it into the veno-venous ECMO and the veno-arterial ECMO. So veno-venous is something which we prefer for oxygenation, and veno-arterial is for the hemodynamic support. So as the name suggests, you take the blood out of a vein, preferably from your femoral vein or something, and you return the blood also into the vein in a VV ECMO. Then veno-arterial ECMO, the return goes into the artery. Now if you look at the circuit, you have a drainage cannula which kind of removes the blood. There is a centrifugal pump which generates a non-pulsatile flow. There is a membrane oxygenator which oxygenates the blood and removes the carbon dioxide. Then you have the return cannula that is returns the blood into the body, and you have various sensors and safety equipments also. So that is kind of a, so if you see from here, you have the drainage cannula into the pump, an oxygenator which is connected with the blender and the heater, and this goes back into the patient. Here you see it's from a femoral vein into the internal jugular, it's a veno-venous kind of a circuit. And this is how your traditional ECMO machine would look. You have a console, you have a hand crank in case of a power failure and things like that, and you have a pump, you have the oxygenator, you have the return cannula, and the blender and oxygen source as seen there. Sorry. Okay. So in ICU, there are two kinds of cannulations for the ECMO. One is the central cannulation, which is usually reserved for the surgeons, and in ICUs we go by the percutaneous cannulation. And so the common sites which we prefer for a venous cannulation would be the internal jugular, femoral veins, or the direct right atrium, predominantly in the pediatric population, not much in adults. And the arterial sites could be, usually we go with the femoral arterial line. And sizes, the usual cannulas usually range from 16 French to 23 French, and theoretically we need TE to confirm the exact position, but at times we wait for the X-ray to come and then kind of correct the cannula tips. And also all these patients usually need to be on an anticoagulation for preventing the clotting. We go by, traditionally you go by the ACT time. We try to maintain the ACT time between 160 to 220, and continuous heparinization to maintain the targets. Why? Because a significant amount of blood is outside the body and circulating, right? Okay, so we'll one important thing which we need to discuss today is when to call for ECMO. It's not about the functioning or the intricacies of ECMO, but we need to be aware when one should be thinking about ECMO in a patient. So first thing would be to make sure that the patient meets the ARDS criteria. We have already kept the patient in an ARDS-led ventilation protocols, low tight volume with platypus less than 30, and you have already used your high PEEP strategies, probably attempted your prawn ventilation, neuromuscular blockade. So all these kind of conventional measures which are meant for ARDS management is already done, and even then the patient is meeting with certain criteria, as in the earlier trial, where if the PaO2 by FiO2 ratio remains less than 50 after more than 3 hours on an FiO2 of 80% with PEEP of more than 10. Clear? Or the PaO2 by FiO2 ratio is less than 80 at 6 hours. Or there is a severe hypercapnic failure also, but predominantly we consider ECMO in a hypoxemic kind of a situation. And one thing which has been recommended is to go by the Murray score. So these are the various components of the Murray score. That is your hypoxemic index, which has again everything has a score of 1 to 4. Based upon that range, if it is less than 100 PaO2 by FiO2 ratio, upfront the patient gets a score of 4. You have a chest X-ray depending upon the number of quadrants of involvement. You have the PEEP limits which you have kept for the patient, and based upon the score, if it is more than 3, there could be a strong consideration of ECMO. So with ECMO, always think about the other complications which comes with it. Always think about bleeding as a major complication because you're going to keep the patient paralyzed. Again, thrombosis, blood is going out of the body and circulating, high risk of thrombosis. Risk of infection is quite high. Hemolysis, and also in the peripheral veno-arterial ECMOs, you need to think about limb ischemia and vascular injuries also. But then that is not the thing. The success of ECMO often depends upon the center's experience. The ethics part of it, always consider ECMO when you see some kind of an exit path. It's not that you put a patient on ECMO, it should be ideally a bridge to recovery or a transplant, or probably you're going to be stuck with the patient for quite long. Outcomes, most of the recent studies show a survival rate of around 55 to 65% for select cases in VV ECMO and close to 35 to 40% in VA ECMO. The cost still remains a significant challenge in our part of the world, with various centers ranging from 2 to 4 lakhs just for the institution cost and daily cost of around 30,000 to 60,000 based upon the centers. Okay, so we are done with it. And we will end slightly on the lighter note, which I don't know how many of you saw this paper. Anybody saw this? Okay, this was a paper recently, in October 20th, safety and tolerability of intrarectal blood fluorodecalin for enteral ventilation in a first-in-human trial. Okay. So, they are trying this concept of enteral ventilation as an emerging approach that provides partial systemic oxygenation independent of pulmonary gas exchange, enabling lung rest. And a first-in-human study demonstrates that intrarectal administration of non-oxygenated blood fluorodecalin is safe, feasible, and well tolerated. So, probably we might be calling a gastroenterologist soon when the patient goes into hypoxemia. Thank you. And so, wait a minute, slide. So, if anybody wants the presentation, it's right there.